Nancy Christie Sobolewski. Cassie Caldera. No. Jeremy. No. Doesn't look like we have a quorum, Dr. Burby.
So thank you all for attending. We're just waiting for a quorum, so just hang on for a few more minutes there, and hopefully we'll have one or two more folks be joining us.
Scott Houchin. Yes. Tina? We have 6 members.
Okay, it looks like we have a quorum, and so with that, we'll go ahead and call the meeting to order. Welcome to the Medical Advisory Committee meeting for Wednesday, March 10th. We'll go ahead and start with some introductions. I'll go ahead and start. I'm Dr. John Burley, the EMS Medical Director for Monterey County EMS Agency.
Teresa Rios, EMS Director.
Jeff DeAndrea, EMS Analyst in Mohawk.
Deborah Hopgood, EMS Analyst.
Kimberly Hernandez, EMS Analyst.
Steve Brooks, EMS Analyst.
Laura Wallen, Health Program Coordinator.
Scott Houchin, First Responders.
Will Hiller, AMR CES.
We have 7 now.
Good morning, Jeff Horner, Director with CalStar.
Cole Click, Natividad Medical Center.
And Noah Hawthorne, Me Memorial.
Michelle
Kalinsky.
I got Dr. Kalinsky. Was there another person on there?
We saw Tina, Chief Nieto.
Tina Nieto Lachis.
Thank you.
Jeannie Alexander, Big Sur Fire.
Dr. Click was also
He already.
okay. All right.
Great. Well, thank you again, and welcome. We'll go ahead and start the meeting with an opportunity for public comment. So any member of the public may address the subcommittee for a period of not to exceed 3 minutes on any issue not on the subcommittee's agenda. MAC will listen to all communications, but may not take any action. Any public comments?
Hi, this is Reb Close from CHOMP and from the Prescribed Safe program. Teresa and I were chatting the other day, and I would like to bring up 2 issues as a public comment. One is, I think everyone is well aware on the committee of our significant increase in overdoses, both fatal and non-fatal, not just in Monterey County, but across the nation. And what we were talking about is, in response to this, there are a couple of items that I feel are fairly low ask, but I think could make a big difference as we're trying to track overdoses and know what's going on in our community. The first of which is ODMAP, and I brought that up to the committee actually just right before COVID. But right now, I think it's actually even more important as we're coming out of our response to COVID, and we seem to be making great strides there. We are seeing an incredible worsening in our overdoses. And so what I would like to do is to ask that we could readdress ODMAPs. There are a number of different methods for inputting data. One involves an integration with ESO, but the other ones are actually plug and play and ready to go now, where either on-scene information can be put in, or we could have data sets with no patient identifying information, but data sets sent that could be uploaded. So we can have an idea of where to focus our efforts for outreach and for naloxone, and how we can get to our victims prior to, unfortunately, what has been resulting in fatal overdoses after a non-fatal overdose. And I will say, since we went live with OD Maps, and I've been inputting information, I've put in over 700 myself into the map. It's not that big of a lift, but I'm hoping we can find a way to actually get more information than just the cases that are available through the coroner's office and those that come through CHOMP. The second quick thing I'd like to bring up in my remaining time is leave behind naloxone has been, the protocols are written and ready to go. My understanding is that each individual agency needs to determine how they're going to do the leave behind program. The naloxone is free. It's through DHCS, and I can help anybody with the application. And then we were putting together kind of little kits to go with it that you can literally leave on scene for patients, family members, anyone that you think could benefit from having naloxone in their home or on their person. And so I would ask that if it's possible, I am reached out to and I can help provide all of that information. My email is easy. It's reb.close@chomp.org. And that is my time, but I want to say thank you. And I look forward to collaborating on this.
Thank you, Dr. Close. Really appreciate your work in the area, and we'll work on responding to those two requests.
Eric Owelling.
Eric Owelling, Chief Owelling.
Good morning, everybody. Yeah, I was having a little technical issues, but thank you for unmuting me. No specific comment, just I'm in the meeting.
Welcome. Thanks for joining us. Anyone else have any public comment? Okay, hearing none, we'll move on to the next item on the agenda, which is approval of past MAC meeting minutes. You've had an opportunity to take a look at those minutes. If we could get a motion for approval.
Dr. Burley, quick comment if you have a moment.
Yes, sir.
This is Noah Hawthorne. So I just noticed that Me Memorial still has a vacancy on those minutes, and I believe that I'm the representative, as you and I have discussed, and I was also at that meeting, and that's not recorded in the minutes.
Perfect. Thanks for bringing that to our attention, Noah. And again, welcome to the committee. We appreciate you being here. Any other comments or corrections on the meeting minutes? Can we get a motion for approval?
Motion to approve with the correction.
Teresa, thank you. Has a motion?
No, I can't.
Oh, sorry.
The motion
You
needs to be-
confused me, Teresa.
The motion needs to be with the correction.
Huh?
The motion needs to
With
be
the correction for Dr. Hawthorne.
This is Tina Nieto. I move to approve the minutes with the correction added by Noah Hawthorne.
I'll second it. It's Michelle Kalinsky.
Thank you. And all in favor?
Aye.
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 Opposed?
Dr. Burley, we have to do roll call.
Oh, wait. So because of the virtual meeting, I'm reminded we need to do roll call for the vote. So we'll start with roll call.
Dr. Kalinsky,
Aye.
Dr. Click,
Aye.
Dr. Greenson, not here yet. Christy Sobolewski's not here yet. Cassie's not here.
I'm here.
Cassie, okay, Cassie, thank you.
Aye.
Jeremy Hadland, have you joined? Michelle Villanueva, let's see, Dave Craddock, have you joined? Greta Steinbrunner, Scott Houchin,
Aye.
Will Hiller,
Aye.
Jeff Horner,
Jeff Horner, aye.
Tina Nieto.
Aye.
Thank you. Motion carries.
Thank you all. Which brings us to the next item on the agenda, which is EMS recognition. And Steve Walsh has some items.
Good morning. Many of the committee members are aware that we have had an EMS recognition program for a number of years, started back in 2010. Due to many circumstances, not the least of which is COVID, we have been on a bit of a hiatus. And we are very proud to be continuing our EMS recognition program today. And we have two people to recognize. One of them, and this is number B on our agenda, is Mary Hudson with Monterey Fire Department, who has just been fabulous in helping to combat COVID and help move many of our other fire agencies into being able to provide vaccinations with their paramedics and EMTs. So with that, we have a couple of items that we have created for the individual. One of them is a framed certificate, and these are unique to the individual. There's no two of them that are alike because no two of our EMS providers are truly alike. So what it says is certificate of appreciation is awarded to Mary Hudson for encouraging and fostering excellence in emergency medical services. Your attention to detail, strong work ethic, determination to do the job right the first time, and selfless desire to help others in the fight against COVID-19 has been recognized and appreciated by those with whom you work. So that's the certificate we've created for it. We also have two items. Dr. Burley, if you'd like to come up to present these. We have two items that go along with the certificate. One is a challenge coin that we created specific for this program, and it is engraved in the back with her name and position. And we also have a lapel pin. And if you look carefully on the lapel pin, you will see that it is also, has the word excellence on it. These are earned. We have some that we've given away, but the ones with excellence are earned and well-deserved. So Dr. Burley will get to present these tokens to you, and I will be taking a couple of pictures because we like to memorialize this.
So Mary, on behalf of the EMS agency, I'd like to present this certificate of appreciation for all of your hard work and dedication to the field of EMS and the service of the citizens of Monterey County. In addition to this certificate, which I'll hand to you here, we have our challenge coin and lapel pin from the county as well. Thank you for everything that you've done, and it's been a pleasure having you serve with us.
Thank you very much.
Thank you. I think I got some pictures. Thank you. The other person that we are recognizing today, Steve Walsh, paramedic with AMR, is on duty today, and we had hoped that he'd be able to make it. He may yet show up, but if he doesn't, let me read what we said about him. Steve Walsh, who I've known for a number of years, even before I came to work for the EMS agency. He was working for the Central Santa Cruz Fire District and proved to be quite an excellent firefighter, paramedic, chief. He has come to work in Monterey County. And what we have for him is for encouraging and fostering excellence in emergency medical services, your dependability, exemplary patient care, kindness, easygoing manner, and shining example of what it is to be an EMS professional has been recognized and appreciated by those with whom you work. And so we'll be making sure that we get this to him. And we want to say thank you to both Steve and Mary for their fine examples of excellence in EMS. So thank you.
Thank you, Steve. So that brings us on to correspondence, which we don't have any correspondence on the agenda. And that then brings us on to reports. And for EMS agency updates, Teresa Rios has an update for us.
Thank you, Dr. Burley. Good morning, everybody. The first thing I want to report is, sadly, Laura Wallen, our health program coordinator, has decided to leave the EMS agency. Her last day is Tuesday, March 16. The agency recognizes Laura's significant contributions to the clinical and specialty care programs in the county. She always showed commitment to ensuring the success of our programs. And we are going to miss her, but we definitely wish Laura well in the future. We are working to create an implemented transition plan for Laura's areas of responsibility. We will follow up with an email. We're having to do some shuffling internally, but in the interim, please feel free to send all of your inquiries to Deborah Hopgood, our EMS analyst. Some of you have already started working with her, and you by now know that she comes with a wealth of experience in these programs, and she is right, to take on the programs that the clinical programs. Next, you just heard Dr. Reb Close from Prescribe Safe program make an ask to the system. She did approach us about the OD MAPS program. She does, her goal is to connect directly to the countywide data system through our ESO program to extract data related to overdoses in the county. We provide aggregate data right now, but she wants more real-time data that she can access. We are working with her to see what is it that we need to do, because we have an agreement with ESO, and then we also have the sharing agreements with each of the agencies in the county, with the exception of, I believe, 3. So we can, the EMS agency can't single-handedly just, make an agreement. We need to work with all of the entities on how to do that. So the first step was to invite Dr. Close to come and speak to the committee. I also brought it up at the Monterey County Fire Chiefs Association meeting. There seemed to be support for that. So we will keep everybody posted in any progress that we're able to make in this area. Lastly, the RFP for a new ambulance provider in Monterey County closed on Friday at 3 o'clock. Unfortunately, the county did not receive any bids. At this point, we are assessing our options. Our primary goal is to ensure the continuity of services in Monterey County. And that concludes my report. I'll be happy to answer questions.
Are there any questions? Okay, hearing none, we'll move on to old business. And the first item on the agenda is EMS agency response to COVID and a report from Jeff DeAndrea.
Good morning, everybody. The past couple of months, one of the main focuses that we've had is working with fire districts to implement the local optional scope of practice to authorize EMTs and paramedics to act as vaccinators, to be trained and prepared to vaccinate. Right now, from 9 different fire departments, we've got 138 fire medics and EMTs that are authorized right now. There are some trainings happening right now as we speak. Maybe not this very moment, but this week there are still trainings going on, and we expect another couple dozen more, 2 to 3 dozen most likely, from a few different organizations that are wrapping that up. That's been a great accomplishment of the agency, especially right now with everything that's going on. And we're hoping that the Johnson & Johnson vaccine, which is now available, will also provide some more accessibility to a provider status for some of the fire departments. It'll be easier to accept and store the new vaccine in contrast to the prior 2 vaccines that have been available. The MOAC resource request program continues. We've coordinated over 1,500 requests for PPE and various things, as you all know. done a lot of work. It's slowed down at this point, but we got dozens of care providers, nurses, RNs, LVNs, CNAs into hospitals and skilled nursing facilities. And now we're supplying the vaccination effort with needles, syringes, sharps containers, and so forth. So that goes on a very smooth program, and we're haven't had any real glitches there, getting people what they need to stay safe. And additionally, we took some proactive steps with the late January weather event to stay in touch with other Mohawks and the regional coordinator and the EMS authority in Sacramento to be very ready and prepared with some pre-coordinating. And I want to thank Chief O'Elling for his timely email too, which sort of prompted some of that preparedness. And the Mohawk program continues, and we're here. And as always, I urge everybody to reach out if they have any unfulfilled needs. So,
Thank you, Jeff. So that brings us to the next item on the agenda, which is policy and protocol development cycle for July 1, 2021, effective date. And Steve Brooks has a report for us.
As I'm sure you all remember, this item is a continuation from the last meeting where we are looking to bring a couple more policies to this committee for endorsement and eventually implementation July 1 of 2021. There's one policy and one protocol that received a great deal of discussion, and the EMS agency was asked to bring these two items back for committee review and hope for endorsement today. The first policy is policy 4100, I believe. Yep, policy 4100, pre-hospital determination of death. Most of the discussion is related to how this policy relates to protocol C1, but we have made a few updated changes in this protocol. And I think from what I understand, we're pretty much in agreement with this. If you guys have had a chance to look at it and the updated version, are we good to go? Question for the committee.
Steve, we don't have the updated versions to put up on the screen.
Can we get those? Thank you.
Policy
4100. Scroll down a little bit, please. Thank you.
Do you want to just hit the highlights of what has been changed since our last discussion?
So I did these a while back, so I'm trying to remember just there's some fine details. I think we worked on number C there in the policy as far as I think there's a language cleanup is all I could remember on that one. D was not changed from our last discussion, other than I think a small wording change to be a little more specific. Scroll down, please. Yeah, go ahead, keep going. Okay, so
There's a reference to there's a reference to C1, cardiac arrest, asystole PEA. If you scroll up just a touch.
oh, yeah, please. Up, yeah. There we
And
go.
we did make an adjustment. There was a concern that patients who sustain traumatic injury may be in a PEA rhythm that due to a potentially correctable cause, such as spontaneous or traumatic pneumothorax, tension pneumothorax that could be decompressed, or other, perhaps even hemorrhagic shock. And so what we did is we adjusted the PEA rate to less than 20. So really what we're doing is giving an opportunity for potentially life-threatening life-saving interventions on patients who undergo traumatic injury and are in a PEA rhythm that may be salvaged versus patients who are in an agonal rhythm.
Right.
Dr. Kalinsky, you had a comment?
Oh, yeah, I was just wondering, I don't see that there's any separation for blunt or penetrating. So the plan is to keep the algorithm consistent, just because we know that, I guess, with penetrating, it seems that there's more potential for salvage from some of these injuries. And so I was just curious, the decision making.
Yeah, so, in a situation where you have a blunt injury with a PEA arrest with, for example, a tachycardic PEA or a non-agonal PEA, there was also, I did discuss this with Dr. Distante, and there was concern that there could still be such pathologies as a tension pneumothorax that could be correctable. And so we didn't feel that we needed to delineate between traumatic and blunt for PEA, although as you can see, patients in agonal PEA are still considered similar management to those traumatic injury patients in asystole.
So yeah, just to clarify then, with agonal PEA for penetrating, the recommendation is not to try to needle or intervene, it sounds like, and to treat it just as asystole.
Correct. I mean, it's hard to write a protocol to address every possible situation, and I would defer to the judgment of the paramedic on the scene. If they feel that there's a potentially correctable cause, then I don't want to stand in the way of doing a needle decompression. But in general, the protocol has been adjusted so that we're not unnecessarily trying to resuscitate patients who are in asystole or agonal PEA.
Thanks.
Thank you. And then there was also some reference, if you scroll down just a little bit there, just some reference to cleanup on releasing the body to family or responsible party.
This is Tina Nieto. I do have a question. On 2, it says the incident commander is going to be responsible until the arrival of law enforcement or coroner deputy. But then when you go to 6 that you added, now it's saying that you can release it to the family member or responsible party. It seems to be a little in conflict, or how do you clean that up?
So we're trying to address 2 different things and think maybe sequential. So the incident command, whether it's the fire captain or the senior paramedic on the ambulance, is responsible for the deceased until law enforcement or coroner arrive. In an effort to not tie up the EMS personnel, the number 6 has been put in, which would be sequential, so that if there will be an extended time and the coroner's representative is contacted, they may
No, I understand that. I've been on a lot of death scenes. What I'm saying is that it is in conflict. I would just add something to the top. or if it, meets the requirement in 6, or if it meets number 6. Because in 1, you're saying you don't leave until the arrival of law enforcement or a coroner deputy, but then when you get to 6, you're saying, oh, you can leave if the coroner gives verbal approval.
So in looking at this, would that be fixed by including the language of 6 as the next sentence in number 2? Put it all as the same item.
Probably. That way they're not in conflict.
Okay, thank you, Chief Nieto. We can clean that up just a touch there and make that more clear on the protocol. Thank you. Any other comments specifically on this protocol?
Hearing none.
Do you want to bring up C1, Steve?
Yes, C1's coming up next. So we also have protocol C1, cardiac arrest asystole. And so we cleaned up the language as recommended from the last time. If we could bring C1, should be the next one. Go ahead and go down to the flow chart. Great, thank you. All right, so the main thing is, again, from our original version, we've decreased the time for resuscitation attempt of CPR for 20 minutes down from 30. And of course, we've continued the language of where we should consider base contact or transport. And we bring this back looking for further questions and hopefully endorsement.
Dr. Kalinsky?
Yeah, I was just wondering why it lists up to 3 rounds of drugs rather than, 3 or more. It just seems like it's up under discontinuation of CPR, the 20 minutes and up to 3 rounds.
So your recommendation?
Seems like they should have, I think it previously was that they would administer 3 rounds of drugs before consideration of determination.
Okay.
So what you're saying is maybe change from up to at least 3 rounds of
Or
drugs?
you could just remove the words up to.
Yeah, that would be what
And 3 rounds of drugs.
Yeah, because you'll be at 3 rounds by 20 minutes.
that's what they should be. And then I had sent this comment over after you guys sent it to him. And the only other thing I would say in terms of those patients to consider transport is anybody with a persistently high end tidal, because those are potentially salvageable patients. And usually, an elevated end tidal CO2 that's not dropping, there's something else going on that might be able to be fixed.
Would you use 20 or what number would you use?
I'd have to pull the most recent data. I haven't looked at it real recently, but I know that, under 10 portends bad things and above 15, and I don't know if it's 20 is more recent, seems to have a better chance of a positive outcome. So, those are just patients to consider transport on.
So we can add to the list persistent end tidal CO2 greater than or equal to, and if we add a number, that would help.
Is there concern about measurement error on these? Since it's not an intubated patient, presumably. So, through nasal cannula, if the data is not good, how will that impact?
Yeah, I did look at this, Dr. Kalinsky, and there did not seem to be a clear number in the literature that was well studied and reproducible. So I think that's why we had left it off. But if we can come up with literature that would support a specific number, then we could put this in as a caveat. Again, all of these caveats are simply reminding folks to consider transporting these patients. They're not mandates, so it doesn't necessarily tie our hands in situations where the patient is clearly not salvageable but has an elevated end-tidal CO2.
Maybe it's more of a training issue then.
But it could always just be an indication for base contact.
Yeah, I mean, same thing for rising end-tidal CO2. That's what I thought was the big positive prognostic indicator.
So would you recommend putting in a fifth bullet point under the what we have there in red, stating patients with persistently elevated end-tidal CO2 greater than, let's just use 20 for example, or persistently rising end-tidal CO2? Would you recommend putting that in as a bullet point, or do you think that is more of a training issue that is better addressed in the field?
Does anybody know of any other county protocols that include anything, any number or measurement of end-tidal CO2 in determination of death or in determination for transport?
I know that LA was looking at it. I don't know. I know their trial also got stopped during COVID. I do know that, a level less than 10 portends a bad outcome. And if you have, like Nick said, a rising end-tidal or above 20, that seems to show. Some people say it's 15. I don't think that number is hard and fast. Right. So I think maybe, like I said, maybe it's more of a training issue, maybe just a comment in terms of a note. You have the note there for hypothermia, maybe a note of a rising end-tidal CO2 favors a better outcome, consider transport, or an end-tidal 2 of less than 10 portends bad outcome, consider termination.
Okay, well, we can go back and look at adding some verbiage to reflect that. Thank you, I appreciate those comments. Can we move to acceptance of these two protocols with the caveat of adding the verbiage that Chief Nieto had mentioned and that Dr. Kalinsky had requested?
Correct. We can add language regarding end-tidal CO2, and then on the policy 4100 determination of death, moving the item 6 up to item 2 would be the two changes based on the discussion from this committee. And we would be seeking a motion to endorse these items, policy 4100 and protocol C1 with those changes. We would, of course, need a motion.
Again, removal of the up to under discontinuation of CPR and
Yes,
the up
that-
to 3 rounds.
That also.
Okay. I'd move to approve.
I'll second.
Thank you, and we'll go ahead and take a roll call for approval.
Pardon me. Right. All right, Dr. Kalinsky.
Seconded.
Yeah, well.
Aye.
Dr. Click.
Aye.
Cassie Caldera.
Aye.
Scott Houchin.
Aye.
Will Hiller.
Will Hiller, aye.
Jeff Horner.
Jeff Horner, aye.
Gina Nieto.
Aye.
Did I miss anybody who showed up later?
This is Dr. Hawthorne. I'm still in the
Oh.
meeting.
Sorry, thank you.
Dr. Green, or Nick, I'm still in the meeting too.
Dr. Greenson, thank you. Aye for both of you gentlemen.
Yes.
Thank you.
Yes, please.
Thank you. All right, did I miss anyone else? Thank you. All right, so we've motion carried for those. Also, there's a couple of policies here. Give me a moment to get to them. Oh, and there's one other. Protocol N4, suspected hypoglycemia. There was a lot of discussion about this one and how it was written. And what we determined was that it just seemed to be better for a flow chart. So we created a flow chart. So if we could go to N4. Okay, before we get to the flow chart, what we are considering, we've updated the language to reflect the discussion from the last meeting. And that's in here at the top of the flow of the protocol. But now if we could go to the flow chart. The language is basically in this also. And so I would propose that we eliminate the verbal part of the policy or the protocol and go with the flow chart, much like we've done with the cardiac protocols. And so we've made a couple of adjustments to move the person into this protocol. We've elevated the blood sugar to less than 80. Previously it had been 60, but that was mostly to get people into the more aggressive treatments. So we start with 80, find whether the patient is conscious, able to self-administer glucose. If so, they go down the left part of the flow chart. We administer glucose pace, whatever oral sugar we can get into them. And if they continue, we monitor, observe, and ideally transport to the ED so we can find out why their blood sugar's not what it should be. Now, if they are unconscious, unable to self-administer glucose, we continue to want to establish IV access. If we do, then we give dextrose up to 25 grams IVIO, and we allow for a repeat of that if there's no improvement before base contact, and then of course transport. If we are unable to establish IV and the blood sugar is less than 60, then we go right for, if it's not less than 60, we go for glucagon, and then the flow chart then allows a few minutes, 10 to 15 to see if there's improvement. If there's no improvement or the patient continues to decline, then we move over to the establish IO access and give the dextrose intraosseous. If there's improvement in the patient with the glucagon, of course, then we move directly to transport. So I think this reflects pretty accurately what we discussed at the last meeting.
Steve?
Yes.
I just have one comment on after glucagon administration. I think if the patient improves, that should be followed up with oral glucose if the patient is able to take that, even if they're being transported, just because the glucagon is going to be just a temporary intervention.
That seems reasonable.
Yeah,
I agree.
So just an arrow maybe going to the left towards, or I mean, just another a comment in there just saying to follow up with oral glucose if the patient is able to then take it.
We'll try to add a box in there below that for oral glucose because
yeah, whatever makes the most sense.
I'm not sure I can actually make not look like bad plumbing to move it back over to the left column.
No, that's fine. But otherwise it looks real reasonable and easy to follow.
I'm sorry, who? I'm sorry, I was not quite hearing.
David?
Oh, Dave Craddock?
Jednak.
Oh, Dave Jednak?
Unmute. Hi, guys. Hey, just real quick on the 80 range. I know back in the day, the index was 70 to 110 per the Merck manual. And I'm just, it seems like it fluctuates back and forth. So I'm not sure if somebody who's 78, we should be treating with, oral glucose when it's, that range has varied in the past. I don't know what the current range is or if there's new standards around it. But that's just my 2 cents there. Can you hear me?
Yeah, I'm processing what you said. So in my mind, we're doing this because there's some alteration in mental status or other symptomology for accessing 911. I guess that's sort of, we made that an assumption, and what you're saying is, just because a person's blood sugar is less than 80, they shouldn't enter the.
Well, that's just it. I mean, how many times do we run a call where we do a routine blood sugar check and we find them in a lower range, and now we're going to be pushing people to administer whether they're diabetic or not? I mean, we're upping the range for additional treatment, which may or may not be warranted for that presentation.
I guess that may be the case, Dave, but also, the treatment that we're administering for those particular patients who may be less than 80 but are not altered is simply to have them take in a little oral sugar, which is kind of a no harm, no foul treatment. It's not likely to cause any untoward effects. Dr. Klinsky has a comment.
So it's kind of a no harm, no foul, but I mean, I wouldn't want to see it delay the likely cause. I mean, Dave's right. You should not be altered because of a sugar of 72. It's a normal sugar, even in a diabetic when their ranges are 80 to, 80 plus. 72 should not cause your alteration. And I don't want people sitting and waiting to see if they respond to glucose paste or those kinds of things and delaying other treatment. I mean, we probably should go with the standard, which I think the cutoff is not 80, it's 70 or 72, depending upon the reference guide.
Yeah, I agree.
Any other comments on that?
Do you guys take any credence in this relative hypoglycemia? Somebody who's used to living in the 300s might be more symptomatic in the 80s, and so you're going to catch a couple of these outliers, although I do in general agree to the 70s.
Move to 70.
Yeah, I don't have a problem moving this to 70. It's as Steve alluded to, the patient activated 911 or their caregiver activated 911 for reasons. So you're kind of trying to take things off the table. And if a patient, normally lives with a blood sugar that's quite elevated and they present with a blood sugar of less than 80, it seems reasonable to administer a dose of oral sugar if they're awake and alert. At the same time, you are looking for other causes, and if they're symptomatic from with some other issue, then transporting the patient to the hospital. So, I think we put 80 in there to catch these patients that may become symptomatic once they get below 80. But if there's a strong feeling to adjust it to 72 or to 70, I don't have any major opposition to that.
My only concern again is I just don't want to see delays in observation in terms of thinking that this is going to fix a problem that may not be related to hypoglycemia. So as long as, the process is moving once they administer, I don't think you're going to cause problems. I also don't think you're going to fix most patients that are 70 in terms of their altered level of consciousness with glucose orally.
Yeah, and again, this pathway would be, if a patient is conscious and able to self-administer, then they'd get the oral glucose. And certainly if they're altered, you're doing these things to take hypoglycemia off the table as the cause of their altered mental status. But of course, any patients who's significantly altered is a patient who's going to be transported to the hospital. So these things are happening, during transport or happening expeditiously on the scene and then transporting. We shouldn't be administering glucose to a patient who's profoundly altered and then sitting at the scene for 20 minutes waiting for that to take effect. So I guess, for clarity, would you like us to change this to 70 or are we okay leaving this at 80 with the current protocol? I think having it at 80 helps to catch those patients who may have some some changes or symptomatology below that level and doesn't really hurt those patients who get a little sugar, even though they're not symptomatic because they're hypoglycemic. So I'd be in favor of keeping it at 80, but if there's a strong consensus among the group to move it, then I'm okay with that as well.
I'm fine with 80 as well.
At that point, we'd be looking for a motion to endorse this policy or protocol, leaving this blood sugar at 80, adding oral glucose into the flow chart after glucagon administration.
I'll motion. It looks good, Steve.
Thank you. Second?
Jeff Horner.
Second.
I caught Jeff Horner. All right, we have a motion and a second. Roll call. Roll call. Dr. Kalinsky,
Aye.
Dr. Click,
Aye.
Dr. Greenson,
Aye.
Dr. Hawthorne,
Aye.
Cassie Caldera,
Aye.
Scott Houchin,
Aye.
Will Hiller,
Will Hiller, aye.
Jeff Horner.
Aye.
Tina Nieto.
Aye.
Did I miss anybody?
Eric Olon.
He's not a member. All right, motion carries. Thank you. Now, just for completeness sake, if you'll look at the policy cycle staff report, there were a couple of policies that did not receive public comment. We didn't bring those to the committee after the revision way back when. Policy 1020 EMS advisory committees, changing the makeup mostly of the quality improvement subcommittees. Policy 1500 policy definitions, which is an ongoing revision as we update policies. Policy 4040 field trauma triage criteria. Off the top of my head, I don't recall what changes we made there. Policy 4170 EMT expanded scope service provider, which we cleaned up to make it less onerous for the BLS providers to apply to be an expanded scope service provider. Policy 6000 quality improvement program, which again is related to the committee makeup. And policy 6180 patient care records, which has a few additional items that we want to just make sure we've included within that policy to make sure that they're included in the patient care report. So for completeness, it would be nice to have this group endorse those changes. I know you haven't looked at them for a while. They were in your packet. Be happy to discuss any specific one you wish. But again, we received no public comments and are planning to move forward with those. Anybody want to venture forward or ask questions about any of them? We can certainly, they're in the packets. We can certainly bring them up if you want to look at any of them.
Do we have a motion for approval?
Ultimately, what we'll end up doing is we'll put these into place. Again, there's been no public comment on any of the changes. And we'll just make them effective July 1. I'm okay with that.
Do these need endorsement?
It'd be nice, but again, there was nobody commented otherwise on the changes that we've made. It'd be nice to have endorsement, but it's, in my mind, not necessary. We'll just make
I think folks probably haven't had a chance to digest every detail on what they've got in the packet there. So if we don't have a motion for endorsement, then we can go ahead and move forward. Is there any further discussion on any of these items, or we can move forward without endorsement? I think Steve was just looking for endorsement if the group was so inclined, but happy again to discuss any questions or comments. Okay, so we'll move on then, Steve. Thank you for that. This brings us to, you don't have any other protocols to go over, Steve?
Let's see, I think I'm next up on the
You're
agenda.
on new business. So it brings us on to new business. And under new business protocol revisions, off cycle, July 1, 2021, effective date. Steve, you have some more
Yes.
reports.
We've got, so what we have and are bringing to you today are some policy and protocol revisions due to things that were discovered through the quality improvement process, as well as some errors, if you will, in the protocols in the pediatric ones, especially. So we'd like to bring those to this committee. We'll go over what it is was discovered and our recommended changes, and hope for endorsement of these changes as making sense. So if you look at the staff report, you'll see the list of the protocols that we're looking at. The first one is pediatric cardiac arrest, ventricular fibrillation, pulseless V-Tach. And what we found is that the lidocaine dosing was initially 10 to 15 minutes, where it should be 5 to 10. So we've created lidocaine as a 5 to 10 minute repeat dosing up to 3 milligram. That's the only change to that. The tachycardia with pulses pediatric protocol needed some adjustment. The essentially definition of what's narrow and wide was incorrect, and we've adjusted it to 0.12 milliseconds. And that's the only change to that protocol.
Hey, Steve, it's Michelle Kowinski. Can, with regards to the tachycardia, and actually to some
Bring
degree,
that one up. Tachycardia, can we bring that up? Yes, Dr. Klinsky.
and to some degree, I mean, all of these PEDS policies, I still have the same concern that I had before. I mean, with the tachycardia with pulses under your sinus tach, you're transporting those patients to the nearest STEMI center. In our region, that doesn't matter, but that could be bypassing Natividad for a North County case and just result in more time of a rig on a transport with really no higher level of service. A STEMI center is not credentialed to do pediatric cardiology and resuscitation any more than a typical base hospital approved for emergency services. And I don't think that we truly offer a higher level of care. I mean, if I want a PEDS echo, it has to go to Stanford, and I don't have any ability to get an emergent PEDS read. My cardiologists do not deal with pediatrics. And so I query why we made this decision. I've asked this before, but particularly in sinus tach, this makes no sense to me.
And also for South County, Monterey, that involves a 1 hour ambulance trip for some of our patients bypassing Me Memorial for a potential cardiac problem that we could treat.
Exactly.
Right, and also like we have 24-hour PEDS hospitalist coverage at Natividad. I'm not sure what the coverage at the other hospitals in the county is, but I think that these kids should probably start at the nearest hospital, and if they need higher level of care, then probably either be flown or rapidly transported via ground up to a specialty center.
Right. I mean, these sick kids are going to leave, and they can leave from anywhere. And honestly, to some degree, we're one of the hardest ones to get folks out of because we have to rendezvous for our air transports out. And then I'll be honest with you, Natividad has a PEDS hospitalist. I don't. So, you know, I just think that decision, I queried it when we made it before. I do not think an adult STEMI center has a greater capacity to manage pediatric rest.
So I kind of disagree here. In particular, for South County is my major concern. It's not the 3 hospitals, but I don't know if they're as well set up?
So I think we're actually pretty well set up. Our main pediatrics, we have pediatrics on call, pediatric hospitalist, and it's actually PICU trained who just abandoned PICU to come do pediatrics for us. So I think we're as well set up with ER and pediatrics.
You also have a helicopter pad, don't you, Noah?
And we have a helipad.
Yeah. So
Yeah.
So I don't agree, because you don't have in general, so some of the phone calls I get out of there, the person trained in pediatrics does not seem to be, it doesn't seem that much pediatric training beyond PALS. So for critically ill patients and so that's my major concern. All the pediatric cardiac arrests in South County have traditionally come to us, and I'd be hesitant to change that.
Yeah, I mean, this doesn't affect us. I honestly think if we're going to specialize a PED center, we should go through the process of a true PED specialty center before we make a designation based on adult capacity, is my view.
I think with regards to Nick's comments, I think Me Memorial is fine for the starting place. It makes more sense for somebody to end up at an emergency department with board certified emergency physicians and a helicopter pad right there for an initial resuscitation than it does to spend another 40 minutes in an ambulance to go to a center.
Yeah, well, right. Well, there's
Different.
the problem though, right? There's not a board certified ER doctor there all the time.
At Me
right?
Memorial
So-
Hospital? I think there is. Noah can address that.
Absolutely not correct. So there's a new ER physician group since November 2019 at Me Memorial. And everybody is ER board certified, and the pediatrics group is largely revamped as well. So there's been about an 80% turnover in medical staff there in the past 2 years or so.
So, I mean, if your staffing and your nursing is appropriately trained in pediatrics and you've got board certified emergency physicians, I don't know. We do not have a pediatric specialty center in the county. And I can just tell you that I do not get any help from being an adult STEMI center for peds resuscitation. And I still don't know why we're bypassing facilities with this protocol.
So thank you for that discussion. You bring up a good point, and it sounds like there's general consensus among the group, particularly given me's increased staffing and board certification of emergency physicians and pediatric specialists. So it seems very reasonable to adjust the language here to nearest hospital as opposed to nearest STEMI center. Any other comments on that?
Quick question. Is that just for this left column for the probable sinus tach, or are we proposing this across the board for all the other conditions? Stable site.
I kind of think it should be universal, but I definitely think sinus tach.
I agree. I think universal for the pediatric AL or the ACLS or PALS types of policies.
I think especially given that the alternative is at least a 45-minute transport, we're basically looking at Me Memorial, which I think is totally competent versus the ALS ambulance rig. And so I would still vote for universal.
That sounds very reasonable. So we'll go ahead and change the language to reflect nearest hospital as opposed to nearest STEMI center. Thank you for those comments.
All right, so that's the tachycardia one. The bradycardia one was some changes for clarity. We had base contact within atropine box, and we've moved it out. We've have epinephrine, as I think we discussed last time, going directly over to transporting, not waiting to continue to give atropine and pacing. It's moving with the patient. Can we see the bradycardia with pediatric? All right, we'll go down a little bit to the flow chart. So as you can see, we moved the base contact out. That's really the only change to this. We'll go continue on down. And of course, you see right in the middle, everything points to the STEMI receiving center. Do we want to, for consistency's sake, move the bradycardia to the receiving hospital?
Steve, it should go for all your PALS type of protocols if that's the case. Again, the STEMI centers do not confer an advantage in a PEDS case with adult capacities.
Okay, we'll make that change. And then we have protocol EP5, overdose and poisoning pediatric. In this one, the dose of calcium chloride was significantly lower than it needed to be. So we've upped it to 20 milligrams per kilogram for calcium channel blocker overdose. That's the change in that one. Pain control pediatric. We have adjusted the amounts of medication a little bit from 9 to 10.
Can you pull that one up?
We've pain control pediatric. Go ahead and go down. So we've updated the language a bit to be more clear. Changed one of the dosings to more appropriate. I think we've updated the repeat dosing to 10 minutes. And if you'll continue. Then we've, separate there for a second. We also have dilution for fentanyl for the smaller patients, and then we'll go down to the next page. So we give instructions for how to dilute, and of course, a note not to dilute via intranasal. And go ahead and go down. And then we've given dosing charts for undiluted and diluted. One thing you will not see in this, because it's in track changes, is that there will be some color coding to make it much more obvious which chart to use. And that will show up on the final version. So this is the one with the biggest change. And so any comments or questions on this one? Go ahead and go back up, if you would, to the dosing. Keep going up, there. Right in there. Any comments, questions, concerns? It was felt to be unclear, so we looked at this, and I think we've clarified the language a bit. So it's easier to read and follow. And then finally, Dr. Klinsky.
So I was just, with the PEDS fentanyl dosing, I think the dosing from what I've seen usually de-escalates with age away from the 2 mics per kilo. Is there a point? I mean, I think a lot of what you see is, and probably this protocol is not going to work in this age group, but between the 3 to 12-year-olds, they sort of recommend a range of 1 to 2, and then over 12, it's going to be down to 1. Is there any concern? I mean, you guys have a 200 mic max, so I guess it's probably covered, but is there any concern with the IV dosing and repeats?
Our age range for pediatric is up to 8.
Okay, so we're probably out. That's fine.
Are we okay with these changes?
Yeah, as long as we're up at 8.
Yeah. And then additionally, a couple other changes. Protocol CP5, wide complex tachycardia. It was on the website still, but it was folded into the tachycardia with Pulseless CP3. So if you have a CP5, wide complex tachycardia with Pulseless Pediatric, that's been removed. And we found that the dopamine chart attached to protocol EP2, allergic reaction anaphylaxis, didn't go down into the pediatric weights well. So we've completely removed the dopamine chart from this. So there are no dopamine charts at all with pediatric. And can you go to EP2? I think it's in the packet. If not, it's okay. So if you are down with a patient who's truly low blood pressure and you're thinking dopamine, it's a base contact only, and you'll get the dosing from the base hospital. And we have the length-based tape for the paramedic to use as a range to confirm that the order they get makes sense for the size of the patient. Another? Yeah, that's fine. So anyways, those two things have been removed, and we'd be looking for endorsement of these changes. And we'll be moving them because they're off cycle. We'll be moving them through the public comment period, and we'll should have everything ready to go for additional training release with the regular policies cycle.
Can we get a motion for approval?
Again, we can, just push them forward. There's additional comment that may be coming through the public comment period. So we don't necessarily need endorsement. We'll bring it back after public comments anyways to the May meeting. But we'll push it forward for training purposes. I'm okay with that if we don't have it at this time. Okay, thank you very much. That's the what's happening with the policy and protocol revision cycle.
Thank you, Steve. And then you have something on term expirations?
Yes. Would it be all right to go out of cycle?
Yes.
And what we have is Steve Walsh has been able to make it. And so we'd like to go back to what we started the meeting with EMS Recognition. And again, for Steve's benefit, we've had this program on hiatus for a little bit, and we're glad to have it back and recognize people who do amazing work in the field and are people who we really would like to have others in the system look at and be just like them. So I can truly say that with Steve. He didn't hear the comments that I made earlier about knowing him for a number of years and having really enjoyed working with him in the field. But we did manage to say a few nice things about him on the certificate. So I'd like to read that again, just for his benefit. So the certificate of appreciation is awarded to Steve Walsh for encouraging and fostering excellence in emergency medical services. Your dependability, exemplary patient care, kindness, easygoing manner, and shining example of what it is to be an EMS professional has been recognized and appreciated by those with whom you work. So we have this certificate to give you, and Dr. Burley gets the joy of doing that, as well as the other tokens of our appreciation, which include a lapel pin that's different than the one that we gave out to everybody a couple of years ago. This one is earned. It has excellence on it. And so AMR has approved that to be worn on duty. So if you choose to wear it with pride because it's earned. And we also have a challenge coin with your name engraved on it. Jeez. So that You can't sell it on eBay. We'll know where it came from.
And a $50 gift certificate to eBay, right? Okay, well, Steve, on behalf of the EMS agency, we'd like to present you with this certificate of appreciation for all of your hard work and excellence in EMS over the course of the years.
Thank you.
We'd also like to present you with the challenge coin and your lapel pin.
Thank you.
Thank you so much for all of your fine
Thank
service.
you. It's a pleasure. Been a journey.
It
It's
has-
almost over.
No, no.
Congratulations, Steve.
Thank you. Thank you very much. Appreciate it. Are we free to go?
Oh, yeah, you can stay if you want to.
I'll get back in service.
Yep. Thank you, Steve.
I'm going to EMS. Thank you.
Thank you. All right, so MAC membership. Again, if you see on the staff report, we have some members whose term of office on MAC is expiring. The first, basically the end of June this year. And that's Dr. Kolinsky, Dr. Hawthorne, Dr. Click, Dr. Greenson, Christy Sobolewski, and Cassie Caldera. Your term of office expires. We'd like to reappoint you to MAC, and we'd like to have you guys acknowledge, maybe not here, but we'll be in touch to acknowledge that we would have you, we would enjoy having you continue on MAC. Teresa, do you have anything you'd like to add on that one? Okay. That's what I've got for that one.
Great. Well, thank you, Steve, and thank you all for your ongoing service on this committee. It's extremely valuable and very much appreciated, all of your input and great discussions on the issues that are brought before this committee. So thank you for all of your service. We'll move on to EMS System Quality Improvement Program and the CQI tag report from Deborah Hopgood.
Good morning, everyone. We had a lengthy hiatus from holding our quality improvement meetings over the past several months due to COVID and several other circumstances that took place. And within the last month, we've been able to reconvene all of those groups and have meetings for CQI tag, T-Quick, stroke, and STEMI groups. We use this break as kind of an opportunity to do a reset of these programs and have some open discussions about the future of quality assurance and quality improvement as well within the county. So we had some discussions of different capabilities of the organizations, some different philosophies related to QA, CQI. And then we had some discussion about what performance indicators the group might like to see throughout the next year or so, and then some performance improvement projects with the goal of moving from not just a QA focus, but to an actual quality improvement focus and working to identify issues within the system and improve those issues. So one of the steps we did to do that was we sent out a SWOT analysis form. That went out to all committee members and was a part of our discussion within the meetings. So we've asked for those to be returned by March 31st. So if you have one of those, we'd love to hear your feedback, and thank you for the people that have turned those in already. So otherwise, we've got some projects that are already either completed or in process that came out of those meetings. The first one was a policy and protocol meeting for the CQI tag group. So they had an opportunity to review the policies that Steve just went over for you and provide their feedback, and that led to some quality changes before these meetings took place. Another focus of those meetings were MCI related things. So we have resumed daily ReadyNet MCI drills. Another big focus was access to outcome data for our patients. So we've worked with Natividad and Trauma One to get access to their database. We have the initial information from that already, and we're working on a process to do auto updates to that information. So we'll get continuous trauma information. And as of this morning, we've worked with SVMH and made the first steps to get access to their AHA, get with the guidelines information for their stroke and STEMI patients as well. And I think out of those meetings, kind of three big issues came to the forefront that we're working on as well. First being ESO related issues. There certainly seemed to be a kind of a plethora of different problems or questions, issues throughout the county. So we're working on compiling those up into one list and addressing those with ESO, working on patient outcome data things, and then efforts related to MCIs. So reinstituting the drills, working on our plan, working on some training, and then working on active shooter harmer type things and triage tag days were all different ideas that came up from the meetings. I don't know if you have anything to add.
Thank you. No, it was, we had a very good CQI tag meeting and some great ideas brought forth, and so looking forward to more to follow. Any other questions regarding CQI tag or any comments? Okay, that brings us to the next item on the agenda, which is future agenda items. Any items that you'd like to be brought to the committee on future agenda? Okay, hearing none, that'll bring us to the next item, which is announcements for good of the order. Any member of the committee may make announcements or comments. The MAC may not discuss or take any action on any item raised during announcements except to decide whether to place the matter on a subsequent agenda. Any announcements for good of the order? Okay, well, thank you all. That brings us to the next item, which is the next meeting date. The next regularly scheduled MAC meeting is scheduled for Wednesday, May 12th at 8:30 a.m. And the location and Zoom information will follow. Which brings us to the next item, which is adjournment. I'd like to go ahead and, we don't need a motion to adjourn. No. I'd like to go ahead and adjourn the meeting, and thank you all again for participating, and we look forward to seeing you at the next MAC meeting, if not sooner. Go out, have a safe day, and thanks again.
Thank you very much.
Thanks.
Welcome.